Hi, this is going over Chapter 31, Structure and Function of the Heart. The first slide here just goes over the right versus left side of the heart, which will be important to know when you're thinking about right and left-sided heart failure. The next part just goes through the vessels and the veins, which should be very familiar to you. Kind of the same thing on the next slide. The next slide just goes over some parts of the heart. Really, the mediastinum is not a part of the heart, but actually where the heart is located. The pericardium is a membrane that the heart actually sits in, so that when you have a pneumopericardium, this is where the air is actually accumulating between the heart and the pericardium. This is just a diaphragm of the heart wall. This is talking about the chambers of the heart, which hopefully you're well aware of. Different valves of the heart. This is a cross section of the valves of the heart. This is talking about the great vessels of the heart, the inferior, superior, vena cava, and then the pulmonary arteries, and the aorta, of course. This is talking about cardiac cycle, and you should be well familiar with the diastolic and systolic phases of the cardiac cycle. This is just a diaphragm of the ventricular and atrial contractions, and then just the phases of the cardiac cycle. And this is another diaphragm of the same thing. And blood flow, and this should be well familiar to you as well. Then we talk about the pulmonary arteries and vessels, and these are actually the vessels that supply the heart itself. And these become the major players when you're talking about like a myocardial infarction. The collateral vessels, you can particularly have these after you do have a myocardial infarction. You'll develop collateral circulation. And here's just a diaphragm of the cardiac vessels. Then it goes into the electrical control of the heart, the SA node, the AV node, the bundle of His, the right and left bundle branches, the Purkinje fibers, and then the ventricular myocardium. So what's interesting about these all is they all can generate an impulse. Of course, this is the one we want to generate the impulse, but if it doesn't, it fails, it fails, it fails. So the actual individual cardiac muscles can develop their own impulse, which makes it so amazing that the heart can continue beating after all other signs of life are gone for an extended period of time, really. If you've ever heart to try and get that last beat, if you got someone dying. This is just the location of those particular nodes. Hopefully you remember your polarization, repolarization of your impulses that cause contraction of the heart. This should be kind of a review for you. I think some of this information is in your anatomy or your assessment class, excuse me. The heart is operated by the autonomic nervous system with the hypothalamus that go through the medulla oblongata, with varying other impulses, including like baroreceptors and that sort of thing that affect heart rate, and then of course the vagal nerve. So this also kind of leads into the sympathetic and parasympathetic nervous system, and epinephrine and norepinephrine, and acetylcholine. And if you work in an ICU at all, you realize that a lot of these medications, we give a lot of medications to affect the beta-adrenergic receptors, like these are medications like dopamine, dobutamine. So the beta-adrenergic receptors and cause the heart to pump more blood. This is why we give a medication like dopamine and dobutamine to increase the heart and therefore increase blood pressure. This is just going up through some of the unique features of the myocardial cells themselves, which are pretty amazing. This is just showing the differences between the sarcomeres and how tightly woven these are. If you, I'm sure you did this when you were in biology class, you looked at cardiac muscle, and it looks very different from skeletal muscle. This is also just talking about some of the processes that are going into creating that contraction. And you could see that, you've seen calcium here several different times. That's why it's so important to keep calcium levels high. Our patients. Then we kind of go into cardiac output, and of course that is what it says, how much blood the heart is putting out per beat type thing. An ejection fraction is the amount of blood that's left inside the heart at the end of a contraction. Okay, so it basically is telling you how efficient the heart is at injecting blood. So there's always going to be a little bit left in there, but the lower the injection fraction is, the more diseased the heart looks. Okay. Then we get into some of the other things affecting cardiac output, and that's preload. So basically, the more you have in, the more you take out, you can put out in a given period of time. You can have too much preload, and that is when you're getting some right-sided heart failure. So just kind of be aware of that. That blood's got to go somewhere. Afterload is the amount of force that the heart has to generate to overcome the aortic valve to pump the blood out to the rest of the rest of the body. Starling's law is basically the more stretch, the more forceful the contraction. Laplace law is basically the size of the chamber versus the thickness of the muscle wall, I guess, would be the best way to put that. So the thicker and the smaller, the more force there is. Some naturally occurring inotropes are things like norepinephrine, thyroid hormone, and dopamine. So we talked about dopamine a little while ago, but we do create our own dopamine, right? Hypoxia decreases contractility, which kind of makes sense. You get hypoxic here. The average heart rate is 70. I think most of you already know that. Of course, for younger children, that number's higher. For adults, I should say. We do have baroreceptors that help regulate our heart rate. So when our blood pressure falls, these baroreceptors signal to the heart rate needs to be increased and that arterioles need to be restricted. The baroreceptors are located in the aorta and carotid arteries. When they notice the blood pressure is low, they signal for more output. This is just a demographics of the cardiac output, stroke volume times heart rate. You should remember this from undergraduate school as well. This is kind of more the same information. angiogenesis, new vessels. Of course, anytime we have vessels occluded for whatever reason, then they do, new ones do develop around. This is just talking about the vascular bed, the exchange of gases and nutrients and that sort of thing at that point. Talking about the function of the veins, which we know that veins have one-way valves. And so, for instance, in our legs, the muscles of our legs increase. Using our muscles in our legs increases the return of blood flow from our legs, and the one-way valve stops it from falling down. So if you get someone with varicose veins, those valves are not working correctly for whatever reason. Increased pressure, genetics, whatever. And then also if you get someone that's been immobile and standing a lot, or just somebody just standing a lot, they're going to have more swelling and that sort of thing because of decreased venous return. And then talking about the viscosity and of the blood, so that thick blood moves slower. So you think about those people that are polycythemic and how they have basically sludging of the blood vessels, especially on the tiny capillaries. You have laminar flow versus turbulent flow. So turbulent flow is going to cause a sound. Sometimes when you think about like heart murmurs, they're basically the sound because of turbulence. So if you have somebody that has a flow murmur, which is a very common occurrence, which is a nothing type thing, it's just you're hearing the disturbance of the blood going through the heart. Vascular compliance, so if your arteries get stiff, they get less compliant, therefore it takes more and more pressure to move them. Blood pressure goes up, that sort of thing. So we need to be aware of that. Increase in dietary sodium does stiffen those arteries as well. Regulating blood pressure is a very complicated process. So mean arterial pressure, and most of you should know what this is, just kind of the mean. Kind of take the difference between the two. We have a mean. Pulse pressure, the difference between the systolic and the diastolic pressure. So regulating blood pressure. This is talking about those baroreceptors that we mentioned earlier that increase that. Then the hormones that we talked about earlier too, epinephrine, norepinephrine, fight or flight, antidiuretic hormone, which, as it suggests, does not or decreases the amount of diuresis that occurs in the kidneys. And the antidiuretic hormone is going to be also fed into by the baroreceptors and that sort of thing, so that if your blood volume looks low, you are going to start retaining more fluid in your kidneys. In the distal tubules. The angiotensin, renin-angiotensin aldosterone system is all affected by sodium and chloride and water, and very much involves your kidneys. So Once again, we talked about kidneys with blood gases and bicarb, and now we have the kidneys really affecting our angiotensin-renin system for our blood pressure. I will try and find a video that goes over this because this gets to be pretty darn complicated. I'm not sure how many of you guys, nitrous oxide causes vasodilation. We will give inhaled nitrous oxide sometimes to do exactly that if we have pulmonary hypertension. It's basically what we talked about before as far as the cardiac or the skeletal muscle acting to help blood return.